3 times since last Friday in the numbers that are out there. As of now, week 1, which we think is next week, we'll have 46,800 Pfizer vaccines ready to go. Week 2, Moderna steps in, 94,800. Week 3, Moderna, 41,800. At this time, there is no confirmation that we're getting any more Pfizer vaccine. You saw the stories in the paper that there was a shortage, there was differences of how that was acquired. But what that leaves us with, between now and basically the end of the year, we're preparing to receive 183,400 doses of this. Both Moderna and Pfizer require two dosages over a set period of time. The difference is Moderna ships a little differently, and because it is not as ultra cold storage, it's easier to move and store. Those considerations are taken in. That's the type of details that we're taking, that Pfizer may be concentrated more in an urban area where it lands, it's easier to store and in the numbers, and Moderna may be used for greater Minnesota. Those are details that are being worked out. But I caution Minnesotans, this is not confirmed. It's changed several times, and we will adjust accordingly. And I know you're all out there doing the math right now. 183,000 is not 5,695,000 like the people we have in Minnesota. No, but it's 183,400 specifically targeted at healthcare workers and most vulnerable adults in long-term care. So this is a day we've been waiting for. You can be confident in this plan. You're going to see it be bipartisanly. You're going to see the data be out in front of you. More vaccine is coming. Production will ramp up. Soon there will be Johnson & Johnson. There's some excitement out there. Johnson & Johnson, I believe, I don't want to speak out of line here, I believe is a 1-dose application. That makes a big difference. You don't have to go back again, obviously. As supply increases, availability will expand to more people, and this will accelerate. Continued efforts to control the spread are critical. I'm not going to go into it. I may go at the end. My healthcare folks are really great about sending me professional journals. And the Journal of Health Affairs did a story. I would just summarize this for you, Minnesotans. It's unbelievable that these vaccines are 95% effective in what they do. But at the spread that we have right now, the experts are predicting that by the time we get 6 months out and we have the vast majority of people with a vaccination, we'll have 160,000 more deaths. What's important about keeping the infection rate down, had we been at an infection rate where we were in the nation in September at 35,000 cases, not 200,000, even if that vaccine had only been 50% effective, only 60,000 people would die before we got everybody vaccinated. It highlights again, we have got to stop the community spread. We have got to slow this thing down, even with this vaccine. The analogy they said is the vaccine's a fire hose, and it's a pretty darn big one. But even at that, the fire is so big, it's hard to put it out. Our job can be to shrink the fire by not getting it to spread, and the vaccine will help us put it out. So we can accelerate how fast we get out of this, not just by vaccines, but with our behaviors. With that, I'd like to turn it over to Commissioner Malcolm to lead us into a little more of the specifics. But thank you, Minnesotans.
Thank you, Governor Walz. Good afternoon, Minnesota. Well, this is a good day. It's been a long year, and there hasn't been a lot of good news. So it's really nice to be able to be here to give you a briefing on the plans that have been so carefully put in place by my colleague Chris Erzman and her team and all of our partners across healthcare with local public health, tribal health. They've been planning for months, but now it's getting real. It's getting close, and we're very, very excited to be able to share with you how this is going to work in Minnesota. And the governor has done a great job of laying out some of that broader context. And among the principles that he talked about, transparency was going to be very important to us. We know that you're going to have a lot of questions, and we are not going to have all the answers today. But we will do everything we can to keep you updated as we get more information and as we get corrections, as we learn things. We will continue to update you with new information as soon as it's available. As the governor mentioned, we've been working on this for months. We have good, solid plans that are really a framework. They're a roadmap, But we know those plans are going to change as they begin to get executed. Things will change that we can't control, like the federal distribution schedule, as the governor has laid out. We also know that we're going to learn as we go and make improvements in these plans. This is really an unprecedented effort. It's very complex. There are complexities to this. The scale of this has not been done before. We are very fortunate in Minnesota that we really have a very solid base from which to move here. We're quite good at immunizations in Minnesota. Chris and her team and all of our partners have got a really solid foundation underneath this work, but this is going to be complex. And we know, for instance, that we do not control the distribution schedule from the government, as the governor has said. We've already, just within the last few days, had multiple updates in terms of less vaccine coming than we thought, or less assurance of the amount of doses that we're going to be getting. So we will keep those kinds of numbers updated for you. But anything we're telling you today is what we know today. And we will absolutely correct that as soon as we can. But we do know, even with these initial relatively few doses, we know that we're not going to be able to give as much vaccine as is needed, even for those highest priority populations in the first couple of weeks. So the way in which that we are prioritizing who gets the vaccines first is very, very critical. And I think we are all feeling, and the governor certainly expressed it well, some increased hope among certainly our colleagues, our family, our friends, that things are changing. Things are going to change as we get vaccine. But as the governor has said, it is so important that while the vaccine is rolling out, and it will be probably 6 months before this humongous vaccine campaign is really well underway and for the most part becomes part of the routine way we do vaccinations in Minnesota, it's so important that we keep up those really important public health practices that we know work. As we've said over and over again, so much of this is in our own hands, that together we have got the power to make this forest fire a little smaller, to make it easier for that fire hose to do its job faster. Just want to tell you a little bit more, and then I'm going to turn it over to Chris, about our prioritization scheme here. As the governor mentioned, this started at the federal level. The National Academies of Science were asked by the president to come up with sort of an equitable framework for distribution. Then the Centers for Disease Control and Prevention has an expert committee called the Advisory Committee on Immunization Practices. And they, frankly, advise on vaccine administration for all the vaccines in this country. So they have been working and readying themselves to give us the guidance on the COVID vaccines as they came through the process. And these folks at the Advisory Committee on Immunization Practices, or ACIP, is full of medical and public health experts who've been doing this work for a long time. We've had staff from Minnesota who've been a part of that ACIP process and still are. So their guidance has been really critical in helping us make the smartest use of those early, small amounts of vaccine to make the maximum possible impact. That immunizing for impact that the governor talked about. If we can get this vaccine to the people who are most vulnerable for poor outcomes, and the people who take care of the people who need care, that will be the biggest bang for the buck, so to speak, for those early relatively few doses. We're hearing a lot from groups that want to make sure that they're on the priority list. They'd like to move up the priority list if they can. We think that's a good sign. We appreciate that folks are interested in getting this vaccine and see the value that the vaccine can bring to their communities. And we are absolutely committed to getting the vaccine to every Minnesotan that wants and should be vaccinated. And we are not going to stop our efforts until everyone is vaccinated that wants to be. But in the meantime, we ask for your patience and your continued collective work and individual work to do the things that we know will slow the spread of this virus. Exactly how long we're going to need to be keeping 6 feet apart and avoiding close crowds and wearing masks, we don't know any of that yet. We know it will be a while. We know it matters. We know it can help keep that forest fire within some level of control that will help the vaccines to do their work better and faster. So we just want you to be assured, as the governor has said, that we've got a solid plan in place, that it is based on sound science and a real commitment to being as strategic as possible, but also as fair as possible, and to really make sure that the people who are suffering a disproportionate burden of COVID disease are among the first to be vaccinated here. I just want to say just one more final word about how grateful I am for the expertise and the incredibly hard work of our staff at the Minnesota Department of Health under Chris Erzman's direction, and all the partners, the local public health partners, tribal health, our health care partners, partners in long-term care, so many people working just tireless hours and bringing just an incredible degree of skill and thoughtfulness to this process. So with that, I will ask Chris Erzman to give you just another level of detail about these processes. Thank you.
Thank you, Commissioner. I too am excited to say that vaccine is coming soon. Now, no vaccine has been officially approved yet, but as you heard, both Moderna and Pfizer have submitted their data from clinical trials to the FDA. And we expect that the FDA will be making a determination on Pfizer vaccine on December 10th, and then on Moderna on December 17th. So we're very excited about what will be coming in terms of vaccines. These are the first 2 vaccines to go through this approval process, and we know that there are other vaccines that are currently in clinical trials. So we can expect that there will be more vaccines and more vaccine availability coming online in the next months. Even though these vaccines have not yet received official approval, there is still a lot that we know about the vaccines. Both Pfizer and Moderna have indicated that their vaccines have 95% efficacy, or are effective 95% of the time. And just today, data came out to suggest that within our elder populations, those 65 and older, that the Pfizer vaccine also has good effectiveness. As the governor said, both of these vaccines have had to meet strict safety guidance. So even though the process has been expedited, that does not mean that safety has been compromised. So these vaccines have gone through the same rigorous clinical trials that we expect from all of the vaccines that are approved in the United States. One of the things, as the governor said, that's been done to make sure that vaccine is available more quickly is that the manufacturers began producing vaccine before they've had approval. The federal government funded this, and what it meant was the vaccine could be ready right away, and we didn't have to wait for manufacturing time. Now, if a vaccine doesn't meet the approval process, that vaccine will not be used and it will be discarded, but the manufacturers didn't have to bear that cost. So that also helped to speed things up. I want to also acknowledge that it takes 2 doses of vaccine with these first vaccines that have been submitted for approval. So people will need to get 2 doses of vaccine, and I want to keep in mind that the time between the doses is roughly about a month. For one, it's 21 days. For the other, it's 28 days. But it's roughly a month between the 2 doses of vaccine. And then if you consider that it takes our body's immune systems a little while to develop immunity, we're saying that it takes about 6 weeks between the time when someone receives their first vaccine and when they might expect to have protection from COVID. One of the things that we also know is that these vaccines protect people from disease. So the endpoint, or the thing that the people in the clinical trials were looking at, was disease. And so we know that the vaccines protect against disease. We have less information about what they mean for infectiousness. And that's another reason why it's so important that we continue to wear masks and socially distance until we have a little bit more information about the vaccines. The vaccines will be initially recommended for adults because that has been the group that's been primarily part of the clinical trials. Children have been added more recently, and so the initial focus for vaccination will be on adults. And then, as the governor said, vaccine will not be required or mandated. Ultimately, all Minnesotans will have the opportunity to be vaccinated. It just won't be right away for everyone. Vaccine will be rolled out in a phased approach, and this is because we won't have all the vaccine that we need or want initially. So as more vaccine becomes produced, then we can increase the people who are able to be vaccinated. But with limited number of doses, we've had to prioritize who should receive vaccine. And as you heard, the National Academies of Science released a report that gave us an ethical framework for decision making. And with that guidance in mind, then the CDC, ACIP, or that Advisory Committee on Immunization Practices, provided more specific guidelines on priority groups. And we will be following those ACIP guidelines as we make our recommendations. And as we move from one phase to the next, that will really be dependent on vaccine supply. So as you can see from this graph, whoops, did I move ahead? As you can see from this graph, as we have more doses of vaccine, we can move to different groups. Here you go. In terms of phase 1A, this first phase that we're looking at for vaccination, CDC's ACIP recommended that healthcare personnel and long-term care residents be included in phase 1A. That's the first box on the bottom there. We know that there will be additional phases, and right now it's projected that phase 1B will focus on essential workers, and phase 1C will look at individuals who are 65 and older or individuals who have underlying health conditions. Now we know that that could possibly change, but that's who we think will be recommended for vaccine in those subsequent phases. It's important to keep in mind as well that this will continue to open up as more vaccine becomes available. Whoops. I think I'm clicking too hard. Apologies for that.
They jump around a little bit.
Oh, they do. Okay. This is a slide that you saw with the governor. He presented this as well. And I want to acknowledge that we will be receiving our vaccine in Minnesota in batches. While we have some of the projections, they are just projections. And as the commissioner and governor said, these have changed over the last 3 days, and so we've had to continue to make adaptations, and that's why we are not confirming some of the numbers. But this is based on the forecast that we've received from the federal government. And as you look at these numbers, as the governor said, keep in mind that Minnesota's population is 5.6 million people. We know that all the people we're estimating that would be vaccinated in phase 1A total 500,000. And so you can see that even with the doses that have been projected, we don't have enough vaccine to vaccinate that whole group right away. And if we just look at staff in high-risk settings and for long-term care, it's about 298,000. So that means that we have had to do some additional sub-prioritization in order to determine who will get the limited number of doses. And there are a lot of considerations that have gone into determining those subgroups. And as you've heard, our goal is to immunize for impact. We want to make sure that we're vaccinating where it will do the most good. Folks that have been most impacted by COVID and the individuals that we rely on to care for them. I think, as you know, our pause that we're in right now was to a large extent determined because there were so many challenges in our healthcare system in staffing. If we can vaccinate those individuals, that will help address that challenge. When we looked at having to sub-prioritize, this was not something that we wanted to do alone at the department. And so we brought together a vaccine allocation work group. And this is a group of experts from a variety of backgrounds and organizations who helped advise us on the sub-prioritization of vaccine for phase 1A. They brought a broad perspective to our planning and helped us make sure that we were considering all aspects as we had to make some very difficult decisions. The group has met 3 times since September, and you can see the membership there, and we are incredibly appreciative of their input in our process. We had them meet actually last Friday in an emergency meeting because we had just recently heard from the ACIP about their prioritization, and so they helped us with this subcategorization. And I want you to know that the guidance that they put together is posted on our website. So I'll be going over some of the details, but if you'd like to see the full guidance, it is posted on the department's website. When we looked at how we should distribute vaccine, there were two factors that we looked at. First of all, we looked at the number of healthcare workers in a region or in the state, as well as the number of residents in long-term care facilities. But then another consideration, in addition to just the number of people that needed to be vaccinated, was something called a social vulnerability index. And that identifies communities that are at risk. And we've seen that some of these communities who are at risk because of factors like socioeconomic status, housing, different things like that, put them at greater risk for complications from COVID. So that was worked into our decision making, and you'll see a little bit more about that in a bit. In addition to looking at just the number of people who needed to be vaccinated and that social vulnerability index, we also used, as the governor said, some criteria that were established, some ethical principles. That is the risk of infection, people who either work or live in settings with a higher risk of transmission of COVID. Risk of severe morbidity and mortality, those individuals who have experienced greater disease and death from COVID. In addition to that, risk of transmitting COVID to others, either at work or home. So these individuals have priority because they live or work in settings where transmission is more likely to occur. And then finally, the risk of negative societal impact. Individuals have a higher priority due to the extent at which society relies on them for their health. And so those were the factors that were part of our decision making. And as I said, we are in the pause because we needed to make sure that our healthcare systems could continue to maintain. And so vaccinating healthcare workers really makes a difference for that. So we looked at phase 1A in 3 tiers. So in the first priority group for phase 1A, we focused on people who have more direct contact with individuals who have COVID-19. That is staff that may be working in COVID units in hospitals, staff working in skilled nursing facilities, certain emergency medical services personnel, individuals who are doing testing for COVID, and community vaccinators. And I want to acknowledge that when we're talking about this, even though I use the term healthcare personnel, it's all the staff that are providing services. So it's not just individuals who have licenses, it's the dietary aides, it's the housekeeping, it's all the people that are making sure that we can care for these residents and patients. And then when we look at long-term care settings, the first priority is our skilled nursing facilities because that's where our most vulnerable Minnesotans reside. In the second priority group, we expand things a little bit more to include other healthcare personnel in hospitals, urgent care settings, and dialysis centers who provide, again, direct patient services or handle infectious material. And then also staff in assisted living facilities. And assisted living facilities is a term that we use, but technically in Minnesota, it's referred to as housing with services with an arranged home care provider. And for long-term care residents, the second priority group includes residents living in those assisted living facilities, again, technically known as housing with services with an arranged home care provider. We've learned a lot in the process of making these determinations. And then finally, the third priority group includes all remaining healthcare personnel that were not covered in the first 2 groups who are not able to work from home. So this includes outpatient settings, dental offices, home health, and more. And then for long-term care, what it includes is those living in residential care facilities licensed in Minnesota that are primarily serving either older adults, persons with intellectual or physical disabilities, and who are in settings such as community residential settings and adult foster care. So that gives you a sense of how we've prioritized within that first group. And one of the things that I alluded to and the governor talked about is our desire to make sure that we're being equitable in our distribution. And so the vaccine allocation work group discussed how vaccine should be distributed regionally. And as I said, part of that is based on sheer numbers, the number of staff that need to be vaccinated and the number of residents of long-term care. But another factor that they looked at was this social vulnerability index. And this is an index that CDC has developed that looks at 15 census tract variables, such as income, employment, type of housing, whether or not people have access to a vehicle, single-parent households, minority status. All those things are brought together in this social vulnerability index. And as I said, locations with a greater social vulnerability were found to have greater disparities with COVID, so higher case fatality, as well as they were locations that were more likely to become hotspots for COVID. So what we did was we suggested, or the group suggested, that we allocate 85% of the vaccine on a pro rata basis, and then 15% of the vaccine based on social vulnerability. Whoops. And so what you can see here is that it makes a little bit of a difference by region. So certain regions will get just slightly more vaccine than others based on that social vulnerability index, but it doesn't in this case greatly make a huge difference in terms of vaccination distribution, in part because we're looking at individuals who are employed and based on their workplace. The governor talked about how we'll be distributing vaccine. Vaccine does not come to Minnesota and sit in a warehouse. It goes directly to the providers who are enrolled in our COVID-19 vaccination program. And so vaccine is going to be delivered in two ways. First, for the Pfizer vaccine, it will go directly from the manufacturer to the provider. So it'll be a direct link there. And for the Moderna vaccine, it will go from the manufacturer to McKesson or a distributor, and then from the distributor to the provider. So there'll never be a time when there's vaccine that's sitting, say, at the state health department. It goes directly to the providers. The providers that will be getting vaccine need to be registered with us and enrolled. That's a federal government requirement. And we're making sure that we have a variety of different types of providers. So pharmacists, physicians, we're looking at both clinics and hospital settings. So we want to make sure that we have lots of opportunities for vaccination in lots of different parts of the state. And as the governor said, we do have a hub and spoke model, which means that we have 25 hubs. These are 25 sites that will be getting the initial Pfizer vaccine. They have that ultra cold storage capacity, and then they will be redistributing that vaccine to 118 different spokes across the state. Now, I want to point out that when you see those different locations, these are not sites that are open for public vaccination. With this very limited supply, our vaccination is focusing on work sites. So in other words, if you're a healthcare worker, you will get vaccinated at your work site. So there's not a place now for Minnesotans to sign up to get vaccinated. They will be reached out to by their employer. In later phases, however, there will be that opportunity, and you may be able to go to your local pharmacy or your healthcare provider to receive vaccine. The governor did mention our regional healthcare coalitions, and they have been a fabulous partner to us. These healthcare coalitions have been around since 2002, and they are key partners for health systems and public health responses. It's a well-established system and a network that we have had the ability to tap into in this situation. We've used it for other emergency response situations, so we can capitalize on that existing infrastructure. I also want to comment on the important role that our local and tribal partners play. Both the regional healthcare coalitions, local public health, and our tribal health partners have been planning for this vaccine distribution for months. The regional coalitions are really focused on phase 1A because it does focus on healthcare providers, and so they're helping us coordinate the receipt, the storage, and the redistribution of vaccine in this phase. And we appreciate their expertise. Local public health and tribal health are focusing on all parts of phase 1 because as we move from phase 1A, we will be moving away from just purely employer-based vaccination. And so we are grateful for their partnership. Our local public health partners submitted their plans last Friday, and we'll be working with them to continue to move forward in our planning. The governor did mention the end-to-end test of the Pfizer vaccine. Dakota County Public Health was our test site. We ordered the vaccine for them. It left Pfizer on December 2nd and arrived at Dakota County at 8:15 Thursday morning. And as the governor said, the ancillary kit with the needles and syringes came about 30 minutes later. There was no vaccine, but the good news was that the shipment went well and we maintained the cold chain. Now, this slide is way too much information, and really the point of it is the governor asked me to share it just because when we were going over things and we've been providing him with briefings, he said, people need to know how complicated this is. So the purpose of this slide is really to show you just how complicated some of the details are about these vaccines. So you heard Pfizer has to be stored at minus 80 degrees Celsius. It has to be reconstituted. That means it's mixed with normal saline. Once it is unfrozen, it can only be stored for 5 days. Once you've reconstituted it, it can only be stored for 6 hours. It has to go in doses of 1,000. There's just a million little details with each of these vaccines that the teams have been thinking about and planning for. So we just wanted to make sure you were aware of that. Oops. And then the next question, the governor mentioned the dry ice issue. And you're probably thinking, yeah, they're planning for vaccine. They've got to have needles and syringes. But as he indicated, making sure that we have sufficient ultra cold storage is important, as well as making sure we have access to dry ice. We've learned a lot of things about dry ice in the last weeks and what role it has not only in this part of our economy, but more broadly. So we're looking at all of those details in our planning. And then this is just another example of the Moderna product and some of the details of that product. What I think is important, and the governor mentioned this, is Moderna does have the ability to be shipped frozen at what we normally think of as frozen, like ice cream frozen, and it can be shipped in 100-dose increments. And so that allows us to have much greater flexibility. Oops. And then just how are we going to track our progress? This is so important to us at the health department, to the governor, and to all of you in the state. So how will we know how we're doing and what progress we've made? Well, we'll be providing information on our website. We'll be letting you know how many providers we have enrolled, what our vaccine distribution looks like, both by age, by geography, by type of provider, by race, ethnicity, all of those things. And then also doses administered. So who's gotten vaccination? So you'll be able to track our progress as we go through. Now, obviously, the first thing we put on our website will be provider enrollment because we don't have any vaccine to distribute and no one's been vaccinated. But over time, that information will become more important to you and we'll have more to share. And then finally, I just want to go over the timeline for all this. As I mentioned, the FDA will be meeting on Thursday. We expect the ACIP to then, after FDA makes a decision on the vaccine, ACIP will meet to make a recommendation. And then once we have that, we are planning for about a week to make sure we've got all the necessary provider education and all of those things in place. So we anticipate that it'll take about a week from the time that vaccine is approved and we get the ACIP recommendations before we're administering it. But this just gives you a sense of, that those next steps in terms of vaccination. So we're really excited. We're grateful for the fact that we're at this place. So we want you to be excited too, but we also want you to be patient because it is going to take a while until we can get vaccine for everyone who wants it. And with that, I'd like to introduce Dr. Jill Amberry, and she is on our vaccine allocation work group as well as a pediatrician.
Fantastic. Thank you.
Good afternoon. My name is Dr. Jill Amsbury, and as Chris said, I'm a pediatrician at CentraCare in St. Cloud, Minnesota. I am also a mother of a child with complex medical needs. I am also a patient with chronic lung disease. I am a daughter of high-risk parents and a friend of loved ones in long-term care facilities. I am also a colleague and friend to those who are working in hospitals and ICU settings. And over the past 3 months, I have had the honor of representing the Minnesota Medical Association on the Minnesota Department of Health COVID Vaccine Allocation Advisory Group. The Allocation Advisory Group consists of a diverse group of individuals throughout the state with a focus on ensuring broad representation across healthcare and affected communities. It also includes a group of subject matter experts, including epidemiologists, ethics and health policy advisors, data specialists, and legal counsel. 3 months ago, we began with reviewing general information about vaccine development and the likelihood that when the vaccines were approved for distribution, we would need or would be in limited supply. At that time, we believed there would need to be prioritization and sub-prioritization about how the vaccine would be allocated. While working under the principles of maximizing benefits, minimizing harm, mitigating health inequities, promoting justice, and promoting transparency, we began to develop a plan for vaccine allocation in Minnesota. The group reviewed many different allocation scenarios. We looked at models to determine how distribution of the vaccine may affect areas and populations within our state. For example, as you heard before, we have clear data showing that areas of high social vulnerability are more likely to become areas of rapidly increasing COVID incidence, especially those areas with a high percentage of ethnic and minority residents and individuals living in crowded housing conditions. We also know that areas with high social vulnerability have a higher case fatality rate. Using this information, we recommended that the state allocate the vaccine based on population with some percentage of the allocation dedicated to regions with populations of high social vulnerability. After considering statewide allocation of the vaccine, we then transitioned to individual prioritization. Last week, with science, ethics, and implementation in mind, the Advisory Committee on Immunization Practices, or the ACIP, recommended that healthcare personnel and those working and residing in long-term care facilities be prioritized in the first phase. With limited supply, we also understood that at least initially, we would not be able to vaccinate all healthcare workers and all workers and residents in long-term care facilities. When we worked to develop recommendations around which subgroups of healthcare workers and long-term care facilities would receive the vaccine first, second, and third, we did that together. These decisions are not easy. We understand that many groups, even beyond healthcare and long-term care, want to be in line first to get the vaccine. And that's great. We also know that we will not be able to vaccinate all that we want to right away. So we had to make some hard choices, doing our best to try to be as fair as possible with health equity in mind. By focusing on healthcare personnel, we are able to have a multiplier effect. Protecting healthcare personnel while also preserving healthcare capacity. Focusing on those providing direct care to patients with COVID first, we are maximizing that multiplier effect. Additionally, long-term care facility residents are at high risk of severe disease and death from COVID. By vaccinating this group, we have the potential to improve those outcomes while also reducing hospital utilization, so there remains room and staff for other medical conditions to also receive their care. You've heard it over and over again. These are extraordinary, unprecedented times. Though these specific vaccines are new, just as COVID itself is new, vaccines have been around for hundreds of years, saving millions of lives each year. We are optimistic, but we will continue to proceed with safety and efficacy as our primary importance. We also need to continue to work together. Minnesotans working together has always been our greatest strength. I have seen this in our advisory group, in our hospital systems, and in our communities. Vaccines protect us as individuals, our families, our patients, and our residents. But a safe and effective vaccine is only beneficial to all people when we come together, get vaccinated, and build community protection to help mitigate this pandemic. Thank you.
Well, thank you, Minnesotans. Thank you for taking a little extra time. We thought it was important to try and go into a little more detail. I want to just note this will be the first of many updates around this incredibly important endeavor that we're taking. I too share Dr. Amsbury's belief that Minnesotans know how to do this and can do it. I'd also like to note once again, when we were here back in the end of March, and we were announcing a partnership of testing, which was our only tool at the time, one of the only tools to start understanding where we were at. We announced that between Mayo Clinic, the University of Minnesota, our healthcare providers, and so many others. And a question got asked in there and said, okay, you're going to take this testing, you're going to do this, you're going to launch this. What if it doesn't work? Who's responsible? And at that time I answered, as it should be, me. As governor of Minnesota, that responsibility lies with me. The same is true of this plan that's been put out to try and vaccinate. But I want to be very clear. The responsibility and the thanks goes to the people you've just heard from Chris Ayresman, from Jan Malcolm, from countless people who are out there, to our healthcare systems and others. I'm here to endorse the plan they put out there. I'm here to put a face of responsibility that all of the pieces fit together and that there's accountability to make sure it happens. But I can tell you, your neighbors and the professionals in this state have crafted the plan that is the model for a lot of the rest of the country. We're prepared. We are on the doorstep of starting this. The end of COVID is out there. It's just going to take some patience. It's going to take some cooperation. It's going to take some adjustments as we go along. But Minnesotans, you've come this far. Let's end this thing strong. Let's get this thing right. Let's look out for our neighbors, and let's look for that summer months that we know could be so much different than they were this summer. We're going to take a bit of a break here. We're going to join with a bipartisan group of legislators and experts to take some questions from the press. But I can assure you this information will be put online. We will continue to do everything we can to do a public relations to get this information out, to be as transparent as possible, to come back in front of you and to adjust this plan as needed as the situation dictates, to make sure that every Minnesotan's health and well-being is our top priority. Thank you.